So the next topic is endometriosis and adenomyosis. Okay. So what does endometriosis mean? Endometriosis is the presence of endometrial glands and stroma outside the uterine cavity. Okay. That is endometrium. The endometrial glands are supposed to be present within the endometrial cavity. Okay, but what happens is the endometrial glands are found in the ectopic regions. That is, it is found outside the endometrial cavity. Within the that is outside the endometrial cavity. So that is what is called as endometriosis. Okay, if suppose these endometrial glands are found within the myometrium. Okay, within the myometrium, then it is called as adenomyosis. Okay, for example, if the uterus is like this, okay, and you have a that is there is going to be endometrial glands outside the uterus, like for example in the ovary, okay, or it is going to be over the surface of the uterus forming adhesions, okay, or in the POD, okay, endometrial glands. And if those endometrial glands are found within the myometrium, or whereas if it is going to be found within the myometrium, it is called as adenomyosis. Okay? Yes. So what is the pathogenesis? Pathogenesis is um, there are various theories. Okay, regurgitation theory, benign metastatic theory, metaplastic theory, or it is extrauterine stem or progenitor cell theory. So of this, the most favored is going to be regurgitation theory. So what happens is, instead of uterine blood, okay, what happens? The uterine blood is actually, it has to flow outside like this, correct? But instead, what happens is, it is flowing into the fallopian tube and it is going into the pelvis. You understand? It is going retrograde. So this is retrograde menstruation. So implantation theory, it gets implanted. The menstrual blood, wherever it falls, it gets implanted and it forms endometriosis. Understood? Second is benign metastatic theory. Metastatic theory is where the endometrial glands through the blood vessels and lymphatics, they travel to distant sites, like example to the lungs, to the brain and all, they get travel and then they form the endometriosis there. Okay. Metaplastic theory is mesothelium of the pelvis and abdomen. Okay. By they undergo metaplastic change and they become into endometrium. You understand what is metaplasia? Metaplasia is one type of a cell becoming another type of a cell. The mesothelial cells of the peritoneum, they become endometrial cell. You understand what I'm telling? Good. Extrauterine stem or progenitor cell theory. So what does that mean? Here, the circulating bone cells of the bone marrow, they get differentiated into endometrium. You get what the point is? That is, in the endometrium tissue, instead of being inside the uterus, it is outside the uterus. Why it is going outside the uterus? That is what they are all trying to discuss. Why is it going out? Either menses blood, instead of pouring inside, it is pouring outside. Okay. Otherwise, through the blood vessel, it is going and depositing elsewhere. Or else, the mesothelium of the pelvis and the abdomen, they metaplasia change happens and they inherently become endometrium. You understand? Or the bone marrow stem cells, they become endometrium. Okay, these are the reasons. Other than that, various other theories are implantation theory, coelomic metaplasia theory is what is this? Okay, coelomic metaplasia theory. And then immunological theory, genetic factors, molecular defects, all these play an important role in the pathogenesis of endometriosis. Correct. Okay. So what happens in endometriosis? What happens is here genetic factor, immunological factor, molecular defects, mechanical factors, all these they actually cause implantation of endometrial cells. Okay, once there is implantation, there is going to be addition. So implantation and then addition. Okay, it gets adherent. Once adherent, once it gets adherent, there will be blood vessels, angiogenesis. Okay, and then there will be growth. Okay, there will be proliferation. Okay, and then there will be inflammation, ultimately resulting in endometriosis. Understood? So there will be implantation, addition. Once it goes, implants, gets adherent, gets the blood vessel supply, multiplies and proliferates, and inflammation happens. That is what is called as endometriosis. Okay. Now, what are the risk factors? The same risk factors where there will be hyperestrogenic state. What and all we saw before: early menarche, late menopause. Okay. Uh, Here, nulliparity. In nulliparity, what happens? There is going to be estrogenic state. Okay, because the patient did not become pregnant. There was no progesterone prolonged. There is only estrogen throughout. So nulliparity. Okay, and then there is going to be history of endometriosis in the family. Okay, or any toxins, dioxins exposure. All these are risk factors for endometriosis. Okay. So what are the substances that are being produced in ectopic endometrium? What are the substances that are being produced is cytokines, matrix metalloproteinases, vascular endothelial growth factor, and then there is going to be growth factors, other growth factors, estrogen, prostaglandin. All these are going to be high in ectopic endometrium. Understood? Whereas here, what exactly these substances do is the cytokines, they cause adhesion to the peritoneal surface. Okay, cytokines cause adhesion to the peritoneal surface. Matrix metalloproteinases cause invasion. Vascular endothelial growth factor causes angiogenesis. Okay, and then growth is by growth factors. Other growth factors causes growth. Estrogen causes proliferation. Finally, prostaglandin causes inflammation. You remember the pathological sequence that we saw? Implantation, addition, angiogenesis, and then proliferation, inflammation. Understood? So these are the substances which are causing the problems. Cytokines, matrix metalloproteinases, vascular endothelial growth factor, and others. Okay, good. Now, classification of pelvic endometriosis. Classification here, I'm sorry, this is partially gone. How will we classify? Classification is either there is going to be superficial endometriosis. Okay, superficial. Next is deep, deep infiltrating. And last is going to be ovarian endometriosis. Okay. So these are the classification of pelvic endometriosis. So where and all this endometriosis can happen is, it can happen anywhere. There is no what to say place that this endometriosis will not come. Okay, it can come anywhere. The most common place are going to be, it's going to be the ovary. Ovary is the most common place. Okay, after ovary, it is going to be peritoneum, pelvic peritoneum, pouch of Douglas, uterosacral ligament, rectovaginal endometriosis, all that. Okay, and then it is other regions like appendix, lungs, umbilicus, scar, all these regions. Understood? So the most common endometriotic site will be ovarian, and next will be pelvic peritoneal surface. Okay, anywhere in the POD, uterosacral ligaments, anywhere you can find. Understood? So these are the sites where you can find the endometriosis. How will endometriosis look? Okay, depends on how bad the um what to say, how bad the stage of endometriosis is. Okay, in early stage or in the subtle stage, it will be just like a dot, that like a papule. Okay. So that is early subtle endometriosis. Hemorrhagic is where it will be reddish and flame shaped. Okay. Powder burn appearance is going to be puckered and blue black appearance. Okay. See, there is a puckering in that, right? It's there is a brownish or a blackish pigmentation there, and it is like puckered. Okay. So that is powder burn lesion. It is a classic of endometriosis. And last one is fibrotic. Fibrotic means it may be white or it may be black, it may be pigmented or not pigmented. Fibrosis means after inflammation and all happens. Okay, ultimately what happens in what is the end result of inflammation? Fibrosis, correct? So we saw that in the sequence, the end is inflammation. After inflammation, if you have a chronic inflammation, it will result in fibrosis. Understood? Good. Um, Whatever we saw till now is peritoneal endometriosis, that is over the peritoneal surface. But if you go on to deep that is go on to ovarian endometriosis, ovarian will be once again two types. One is going to be superficial ovarian endometriosis. Second one is deep endometriosis. Superficial ovarian endometriosis is just like similar to that of peritoneal endometriosis. Okay, peritoneal surface. It is there, la? So peritoneal endometriosis. Whereas deep ovarian endometriosis or endometrioma is like a mass. Okay, superficial will be like a sheet or it will be just like along the peritoneal surface, this endometriosis will be there. But whereas deep endometriosis are like a mass. Okay, see, that is this surface lesion will imaginate into the surface, imaginate inside the substance of the ovary, and ultimately what happens? It becomes a large endometrioma. Okay. So cyst wall is either white or yellow and the cyst is filled with thick chocolate colored fluid. So that is why it is called as chocolate cysts. You understand? Good. So this that is ovarian cysts. Ovarian endometriotic cysts are otherwise called as chocolate cyst. Okay. Then deep infiltrating endometriosis is also known as posterior pelvic endometriosis. Okay, by definition, the lesion extends more than 5 mm beneath the peritoneum. They are usually located in the rectovaginal space but may involve uterosacral ligaments, cervix, bowel, and urethra. அதாவது more than 5 mm depth இருந்ததுன்னா, deep இருந்ததுன்னா, that lesion is called as a deep infiltrating endometriosis. You understand? We know there are two different endometriotic lesions. One is superficial, one is deep, and one is ovary. Okay, superficial peritoneal is like a sheet over the peritoneum. அதில் தான் நமக்கு வந்து அந்த early subtle fibrotic occurred இதெல்லாம் பார்த்தோம் இல்லையா, all those. Deep infiltrating endometriosis is what is this? More than 5 mm depthல இருந்ததுன்னா, it is called as deep infiltrating endometriosis. Similar to this, ovarian endometriosis is also superficial and deep. Superficial is just deposits over the ovary. Deep will invaginate inside the ovary and a big cyst will form inside the ovary. Okay, so that cyst will be filled with the chocolate colored fluid and hence it is called as, very good, chocolate cysts. Okay, what are the complaints you have in endometriosis? There will be severe dysmenorrhea. Okay, there will be chronic pelvic pain, ovulation pain, pain on defecation, and deep dyspareunia. Okay, pain. Pain only is the major symptom in endometriosis. Everywhere there will be pain. Okay, we do not know why there is what to say, what the reason is, but there will be pain and associated with that there will be endometriosis. Understood? And there will be triple dysmenorrhea. What is triple dysmenorrhea is the pain will be there prior to the menstruation, during menstruation, and after menstruation also. And that is called as triple dysmenorrhea. That is classic for this condition. Okay. Next is menstrual abnormalities, heavy menstrual bleeding, premenstrual spotting, anything can happen. And obviously, infertility. Major problem here because ovarian endometriosis will alter the milieu of the ovary. It will be inflammatory. So, there will be a problem with embryo formation and implantation also. Understood? Even ovulation also will be a problem. Okay? Yes. So, apart from that, if the endometriosis is going to be infiltrating into the bladder or bowel, then symptoms related to that also can happen. Okay. So, what is the cause of pain in endometriosis? If you think the causes of pain is going to be peritoneal inflammation. Okay. Peritoneal inflammation, activation of nociceptors, that is pain receptors, nerve irritation with deep infiltration, tissue damage, local production of prostaglandins, adhesion formation, and collection of blood in endometriotic implants. So, what are the causes of pain? The pain causes are peritoneal inflammation, activation of pain receptors, and then infiltration into the nerves, and obviously prostaglandins because prostaglandins are the prime factors for pain. Okay, and tissue damage and adhesion formation. Okay, right. So, next comes causes of infertility in endometriosis. So, what are the causes of infertility in endometriosis? What are the causes of infertility in endometriosis? See, that is here everything can be a cause, right from ovulation. Okay, because of ovulation, that is, there can be anovulation. Okay, everything, whatever you think it can go wrong, it might go wrong. Okay, in there is ovulation, anovulation can happen. There is follicle will not come. Even if follicle comes, ovulation may not happen. Okay, even if ovulation happens, okay, the sperm factor, decreased sperm survival, and there will be altered immunity. So what happens? They will not be good. And even if they are good, the endometrium will not support. There will be luteal phase defect. There will be no support for the embryo to grow. And apart from that, there will be too much of inflammation everywhere, in the peritoneum, in the uterine surface, in the ovarian surface, everywhere. Okay. And then mechanical factors. Mechanical factors is because of endometriosis, altered tubal motility, peritubal adhesions and all will happen. So what happens? The ovum will not pass through the tubes to enter into the uterus. Okay. So, and the next thing is sperm activation. I mean, sperm inactivation. As I was already telling initially, the sperms, they will have poor survival. That is, poor survival is actually because of macrophages causing phagocytosis. So, infertility in endometriosis per se is a bigger topic because infertility can, that is, endometriosis can cause infertility in all ways. In whatever way you think of, it can cause ovary, sperm, uterus, tube, peritoneum, general inflammation, everything. Okay. How do you evaluate? Obviously, the evaluation lies with scan first. Okay, only with scan you will be able to identify the ultrasonogram. You will be able to identify the endometriosis. Okay, so here it is not very useful in superficial or deep infiltrating endometriosis because you will not be able to see the lesion. The lesion can be seen only if there is going to be a mass, that is like a ovarian mass. Okay, where it is going to be cystic mass, low level internal echoes, and hyperechoic foci. Understood? Whereas superficial endometriosis or deep infiltrating endometriotic lesions, which are just specks of lesions, they will not be able to be seen by ultrasound imaging. Okay, so for that you have to go for doing magnetic resonance imaging, MRI. Okay, and even MRI, it is very useful in case of ovarian endometriosis only, because ovarian endometriomas will always give you trouble in diagnosis, whether whatever diagnosis we make through USG, whether it is right or not, or if there is going to be any addition that is there, all these can be found by MRI. Understood? Apart from that, then how will we identify the superficial and deep infiltrating endometriosis? Any idea? How will we identify? It's by laparoscopy. You do a diagnostic laparoscopy only by on looking the lesion, you will be able to say that it is going to be endometriosis. Okay. Apart from that, you have other blood investigations like CA-125. CA-125 will be elevated in endometriosis. Okay. So what is the role of laparoscopy in endometriosis? Role of laparoscopy is visualization of the lesion. You directly see the lesion. So you know that it is endometriosis. Yes. Okay, and then you can stage how bad the disease is. You can take a biopsy of the disease, and finally you can assess the extent of the disease and treat the condition. Okay, you go inside, look, assess, treat. That is what is laparoscopy is for. Okay, good. Now once you see, how will you stage the lesion? Okay, stages is minimal, mild and moderate. Okay, minimal, mild and moderate. Here in minimal, mild and moderate, what happens is, this is according to ASRM guidelines. Okay, ASRM is American Society for Reproductive Medicine. It is classified the lesions. This, depending on the size of the lesions, it is classifying the stage of endometriosis into minimal, mild, moderate, and severe. Okay, so stage 1 minimal, the score, that is there are various scores depending on the size, depending on the place where the lesion is. We can easily tell it to be minimal if the score is 1 to 5. Mild in case if it is going to be 6 to 15. Moderate it is 16 to 40, and severe it is going to be more than 40. Understood? Mild, moderate, severe, sorry, minimal, mild, moderate, and severe. Understood? Okay. So you finally, you understood the pathology. We understood how the patient will present with, what is going to be the, what is the pathogenesis of endometriosis, how will you diagnose, how will you grade the disease or stage the disease. Okay. Now coming on to the management. Management part, in most of the gynec places, what is the one drug, wonder drug, which will alleviate everything? Pain, obviously NSAIDs. Hormone, progesterone. Simple. See, that is what is going to do the major job, because here also estrogen is actually a prime factor for, yes, okay. But in depth, this endometriosis, as we think, it's not very simple. Okay. So here what happens is, asymptomatic cases with endometriosis, asymptomatic endometriosis, you can just observe. But if in case it is an infertility patient, you need to evaluate and properly treat her, because if you just leave endometriosis just like that without any treatment, she might land up with higher grades of disease or higher severity of disease, which will be more problematic for her. Okay. And also, there is a notion that endometriosis can be cured or can be treated only with excision. Leaving the endometriosis inside and doing a medical management is like ignoring the problem right now, and later on the problem might be bigger or might get complicated also. Okay. But for the patient's point of view, you can't take all the patients to the OT table. So if the patient is asymptomatic and if there is a minimal endometriosis, observe. Okay. And if in case of symptomatic diseases, once again we have medical management. Sorry. Once again we have medical management. We have minimal invasive surgery and surgical management. So what is the medical management that you know of? Obviously we have progesterone. We have OCPs. Okay. We have GnRH analogs, antagonists. Correct? All these we have been seeing for all the places, right? And uh, androgens. Okay. In minimal invasive surgery, you go with laparoscopy. After doing a laparoscopy, what do you do? What are you going to do? Either you're going to cauterize and burn the lesion, or you remove the cyst if there is any cyst present, or you go for adhesiolysis. That is, you remove all the adhesions that has formed. Okay. What is the sequence, pathological sequence that I was speaking? What is the first one? No. Implantation, adhesion, then angiogenesis, proliferation, inflammation, finally endometriosis, resulting in fibrosis. Okay. So what happens? There will be adhesion formation everywhere. So you remove all the adhesions. Okay. Next, it is going to be laparotomy. Laparotomy is that is a definitive laparotomy means you remove the entire thing. All the damaged parts you have to remove. Okay. Salpingo-oophorectomy, or there is a hysterectomy. And if it is going to be a scar endometriosis, excise the scar. So in surgery, it is going to be excision, remove. You understand? Role of surgery is failed medical. When do you go for surgery is if there is going to be failed medical therapy, infertility, there is a recurrence, or if there is a chocolate cyst of ovule. Okay. See, that's what I was saying. If there is going to be infertility with endometriosis, you absorbing it will make it worse. Removing it will actually stop the disease then and there. Okay. Drugs used in medical management are NSAIDs, progestins, then combined oral contraceptives, GnRH analogs, and gonadotrophin antagonists. So all these already we just saw. Okay. Other than that, specific drugs that you know of is we already saw SERM in AUB, ormeloxifene, correct? And then we have selective progesterone receptor modulator, mifepristone. Okay. And then rest others are newer drugs that are being given. Aromatase inhibitor. Yes, aromatase inhibitor is also being used. Okay. Rest others are all going to be, um, what to say? They are all newer drugs that are used. TN, TN alpha inhibitors, angiogenesis inhibitors, matrix metalloproteinases, immunomodulators, and ERB antagonist. ER beta antagonist. The ER is estrogen receptor. Okay, estrogen receptor beta antagonist. So basically, if you ask what are the treatment plan for endometriosis, it's going to be first is medical management, then it is going to be minimal invasive surgery, and the last is going to be surgery, excision. Okay. Indications for open surgery are as follows. Advanced stage of disease detected. Okay. Large lesion. Medical therapy is failing. Recurrence is coming. Okay. All these conditions you do. See this. Any ovarian cyst or ovarian mass more than 3 centimeters, go for cystectomy. Understood? Yes, that is very, very important. So, cutoff for surgery in ovarian endometrioma is 3 centimeters. Okay. What is adenomyosis? Adenomyosis, as I was already telling, it is uterus, that is the endometrial glands within the myometrium. Okay. So, here the uterus will not be enlarged more than 14 weeks. Now, what is the management of adenomyosis is young women, you just have to once again go with NSAIDs and progesterones. That is the simple one. And if it is going to be older women who has completed family, remove the uterus. Hysterectomy with or without bilateral salpingo-oophorectomy. Okay, right. Come now. mm, What should be the treatment of an 8 centimeter endometrial cyst? Very good. Cystectomy. Gold standard for endometriosis. Good. Laparoscopy. Next. Patient comes with complaints of dysmenorrhea and dyspareunia. Speculum examination reveals bluish powder burn lesion. What is the possible diagnosis? Endometriosis. Yes. A patient comes with complaints of dysmenorrhea and dyspareunia. Speculum examination reveals bluish powder burn. Okay, this is a question. Okay. A couple presented with infertility. Semen analysis is normal. Um, Female has menorrhagia on HSG. There is distal dilatation with fimbria. What is the likely cause? Tubal endometriosis only should be this, because tubal polyp, tubal spasm and all is very rare. Tubal salpingitis can be a cause, but in that uh, female doesn't mean the female should have menorrhagia. Understood? Retrograde menstruation. So it's going this way. Okay. Answer. See, Ah, Hara to live to 38 years. She has completed family, done with everything. Okay. So go with hysterectomy with bilateral oophorectomy. Okay. Yes. Next comes dysmenorrhea. Very short topic. I think we can keep this as a final topic also. Right. So what is dysmenorrhea? Dysmenorrhea is the painful menstruation. Okay. Painful menstruation that it is going to incapacitate day-to-day activity. Either it can be primary or secondary. Primary is where there is no pathology. Secondary is some other pathology is causing pain. Okay. So primary dysmenorrhea is mostly confined to adolescents. It is because of ovulation. Okay. And it is usually cured following pregnancy or vaginal delivery. And what are the reasons is it is because of dysrhythmic uterine contractions and uterine hypoxia. And also, there is going to be tension, anxiety during the adolescence, which can actually cause a psychological pain factor during menstruation. Okay. And then there will be uterine myometrial hyperactivity. That is the squeezing pain that the muscles starts to squeeze. So the squeezing pain will be perceived very severely. Okay. And also there is hyperactivity of the uterine junctional zone. Okay, that is one of the important mechanisms of primary dysmenorrhea. Rest others are factors like prostaglandin, endothelin, vasopressin, platelet activating factor. All these are also going to play an important role in primary dysmenorrhea. Okay, so what are the possible causes of pain? Prostaglandin F2 alpha synthesis and release. That actually causes endothelin, leukotrienes, and platelet activating factors. So what happens? There is increase in myometrial contractions resulting in pain. Okay, because of PGF2 alpha, PGF2 alpha is a vasoconstrictor. Since it's a vasoconstrictor, blood flow to that region is also going to decrease. So there will be ischemia. So ischemia also causes pain. Understood? So what do you know about the treatment? It is drug or it is surgery. Drugs are going to be prostaglandin inhibitors. Simple. So NSAIDs. Okay. And the second is going to be OCPs, combined estrogen and progesterone contraception. In secondary dysmenorrhea, you need to know what is the reason for secondary dysmenorrhea. Okay, the basic reasons can be any space occupying lesion, any lesion in the uterus, which the or any lesion whose vascularity is increasing during menstruation is the reason for pain. Okay, or suppose if there is any space occupying lesion within the uterus, like uterine fibroid, endometrial polyp, or it is intrauterine contraceptive device, anything like that, the uterus also tries to push it out, considering it as a foreign body. Correct? So, all these are the common causes of secondary dysmenorrhea. How will you treat secondary dysmenorrhea is where the dysmenorrhea will be attended only if you remove the cause. Understood? There is another terminology called unilateral dysmenorrhea, where the pain will be only on one side in cases of ovarian endometriosis. Okay, where one side there will be pain. Second is going to be bicornuate or unicornuate uterus. Whichever side the uterus is, that side the pain will be there. Okay, and then there can be that is unilateral location of pelvic endometriosis, or there can be right ovarian vein syndrome. Right ovarian vein syndrome. Okay, where what happens is congestion, pelvic congestion happens in the one side of the pelvis, and the pain will be concentrated there more. So these are the reasons of unilateral dysmenorrhea. Understood? Now, in a 25-year-old lady with primary dysmenorrhea, which of the following statement is true? Which is true? A, correct. No clinically significant pregnant pathology is found. Very good. This Since Jones very severe pain at right side associated with COPD, so they were talking to school during this school cost for children center and they have started with being in this. Usually it is 50 what happens in that physical. What is the next step to Hey, you need to first rule out whether it is a primary dysmenorrhea or secondary dysmenorrhea, whether it is related to any other reason. Okay, or if this is going to be a very simple primary dysmenorrhea, after NSAIDs, you're going to put in for OCPs, but you don't know whether it is primary or secondary. So you have to take the diagnosis, do the diagnosis. That's done by doing a ultrasound. Understood? So the answer should be A. Yes. Pelvic, the BA இருக்கு, but the answer should be A. Pelvic and abdominal USG. Yes. So yes, that's done. Okay. We'll take another session or we'll finish the day.